and honorary senior lecturer at the University of Edinburgh. He has been involved in research on functional neurological disorders for 15 years. And he was the initiative, and he led the changes to the diagnostic criteria, the SK5 and ICD regarding this topic, and has published over 150 articles and chapters, including the first chapter on the topic of functional neurological disorders in neurology and clinical practice. And Dr. Stone is the recipient of the Royal College of Physicians Gilbert Prize for Neurology. And he will be giving us a lecture on a very important and hugely till now underestimated topic of functional neurological disorders.
Good, okay. I'm going to really talk about the role of the physician and neurologist in making a diagnosis and treating these patients. I think for too long we've been regarding this as a problem that we should just send a psychiatrist. Psychiatry has a role with these patients, but I think physicians and neurologists have a primary role. Now, just to start with, I'm just going to show you a case from a colleague of mine, a physiotherapist in Glasgow. This is you can see a young man who's had problems with walking for about 6 months. This is how he looked when he was admitted, walking with 2 sticks. I work with a number of physiotherapists who've developed expertise in helping these patients. Quite subtle things they do, like appearing to support the patient, but actually not using fingertip support. This is a man who'd really lost confidence, was frightened of falling. Even though he had that problem for 6 months, after 5 days of physiotherapy, that was the difference that we could make to the gait. So these are patients that are treatable. I think that they require a certain type of assessment, discussion, treatment. In neurology, things are slightly different to how they are in other specialties, because we make these diagnoses of functional disorders, non-organic, psychogenic, whatever you want to call them, using positive signs. So this is not a diagnosis of exclusion. You do not make this diagnosis just because the scan is normal, because it's weird. I'm going to take you through some of these positive signs. I'm going to talk a bit about misdiagnosis, which is often a fear of particularly psychiatrists, and malingering, which tends to be a concern with physicians. And talk a bit about how to speak to patients about these diagnoses in a way that is constructive and helps them in treatment. A bit about management. If you want to look at more, there's these articles, and these are available on a website that I've made for patients, with information for patients, neurosymptoms.org. This is a study that we did in Scotland, looking at all 4 centres across Scotland, just in terms of, just asking the question, what is it that neurologists do in Scotland? These are nearly 4,000 new neurology outpatients. As you can see, the most common problem is headache. The second commonest problem was this problem I'm talking about today. So a rag bag of functional psychological diagnoses, non-organic, no disease, etc. And even the patients with quite more dramatic symptoms like weakness, movement disorder, blackouts, were as common as all the patients with MS or all the patients with movement disorder. So this is not a rare problem, and it's the same all over the world. And every specialty, of course, has its own functional disorder, and most studies suggest that around a third of outpatients have symptoms that are either not at all explained by disease or only partially explained. So it's a problem in medicine generally. So I had to cut out some of the talk for time reasons. Obviously, I'm not going to talk about taking a history, which is obviously very important, but actually the examination is how you make these diagnoses in neurology. And you have to really find evidence of one of these positive physical signs to make a diagnosis of functional disorder. It mustn't be, there's plenty of neurological diseases where the scan is normal, cerebral ataxia, migraines, hemiplegia, etc. And there's plenty of neurological diseases where presentations are a bit strange. So people with focal dystonia, for example, will have the gest so that they touch their chin and comes back into the midline. Now that doesn't mean it's a functional disorder. And you shouldn't be put off this diagnosis just because the patient doesn't have a mental disorder. So some of my colleagues have great difficulty making this diagnosis in people that they perceive to be normal without depression or anxiety. And likewise, it's quite easy to make a mistake and overdiagnosis in the patient with psychiatric disorder, so someone with a personality disorder, etc. If they have a neurological symptom, it's quite tempting to wonder if their problem is functional, but that's really quite a good way to make mistakes. So let's look at some of these signs. Now let's look at weakness first of all. Now just looking at...
As he walks, the affected leg is stiffly extended at the knee.
And someone with organic home increases. I'm going to switch off the sound temporarily. So this patient has a brain tumour. He's walking as a patient with an uppermost neuron hemocresis. It tends to do with circumconducting gait. And that's what you would see in stroke or other conditions. Here's a patient with a functional leg weakness, and instead of circumducting his leg, he's dragging it along behind him as if it's a sort of solid object, as if it's something stuck on the hip. So if you see that monoplegic dragging gait, particularly if the foot is, if the toe is dragging along the ground, or sometimes the hip is externally rotated or internally rotated, that's a red flag for someone with a functional leg weakness. That was a man, as you can see, an older man in his 40s and 50s, diabetes, overweight. He had 8 admissions to hospital with what were diagnosed as TIAs before someone thought, hang on a minute, this is a bit odd. And his MRI scan was completely normal. He had lots of these positive signs that we're talking about today. These things haven't really changed over time. This is a clip from World War I. Shell shock. It's a man also with a dragging gait. He had some great treatments then. 1 hour later, he's completely better. Skipping over the ratings there. So just to prove that was the correct diagnosis in that particular patient. So these things have always looked the same. On the top row are a group of photographs from the 19th century, from Charcot and others, showing that gait, and then some pictures along the bottom, including some of my own patients, showing exactly the same thing. So in the 19th century, we would have called that hysterical hemocresis or hysteria, and now we call it other things. So that's one sign. It's not as useful as this sign, though, Hoover's sign, which I think is a very useful sign in patients with unilateral weakness. Patients with functional weakness tend to have weakness of hip extension, which, if you think about it, is a bit unusual in patients with organic disease. Even someone in a wheelchair with a stroke or MS tends to have fairly normal hip extension, but these patients tend to be weak. And what you do is a sign that was described in 1908. And you test hip extension, you show it's weak, and then you test hip flexion on their good leg while keeping your hand under the bad leg to show that, to see if the hip extension changes. And in patients with a functional disorder, you'll find that hip extension returns to normal and is strong. So you've then got evidence of internal inconsistency. And let me just show you that in this particular patient. Now, just before I show, so this is a lady in her 30s. She's actually a businesswoman without any mental disorder, very easy to talk to. She's a very straightforward, intelligent woman, and breaking some of the stereotypes about these patients. She presented to Royal Phone in Edinburgh with right arm and leg weakness and also some facial symptoms, which I'll show you later. So she's got right leg weakness. So I'm testing first of all her left leg. Sorry, her left leg was normal. Testing her right leg, you see she's got weakness of hip extension. Now I'm going to ask her to lift her good leg up again, her left leg, ask her to focus on it, but look at the right leg. Look at the extension of the right leg. So extension of the right leg has come back to normal. Movement disorders. People are nervous about making a diagnosis of a functional movement disorder with some reason, because movement disorder diagnosis requires knowledge of a different range of disorders. But nonetheless, there are rather specific signs of functional disorder. In the same way that a 3 Hz resting tremor should make you think about Parkinson's disease, there are features of functional tremor. Now, just stop that for a second. And this is a demonstration video of someone with a left-hand tremor. And the examiner is asking them to copy this movement with their good hand. So let's have a look and see what happens to that left tremor when they're doing that. Okay. So what's happening is that the tremor is in training to the rhythm determined by the examiner. So that's a positive feature of a functional disorder. But you can also have there are two other things that might happen. So if someone has a functional tremor of their right hand and they're asked to copy this movement, then it may be that the rhythm entrains to the examiner's movement. It may be that as they're copying the movement, the tremor stops, and that again would be a sign of a functional tremor. Or it may be that they just can't copy a simple movement of the examiner, and again that would be a positive sign of a functional tremor. So these signs are being tested against disease controls and appear to perform as well as any other clinical sign. Obviously, there are most clinical signs have their limitations. You need to look at them in combination with other clinical factors. Another test you can do is, if the patient has a tremor like that, is to move your finger around like that and ask them to point at the finger and touch it. And again, you might find that their tremor stops as you're doing that. There are brief pauses. There are patients who present with what looks like a dystonia. In fact, it is a dystonia because dystonia really is a description of a persistently altered posture. But these patients, unlike other forms of organic dystonia, can develop fixed dystonia, often sometimes with contractures. And the typical presentation is of a clenched fist or an inverted plantar flexed ankle. So if you see that in an adult, particularly if it's coming after injury, it's often associated with pain. There's an overlap here with what's described as complex regional pain syndrome or reflex sympathetic dystrophy. And that has the qualities of a functional disorder and that can sometimes be cured by some of the treatments I'm talking about. It's associated with other functional symptoms. This is a problem that we increasingly recognise as show me where you feel contracting. Quite a common problem. And it's pertinent to the last talk about acute stroke because this is a cause of apparent face, arm and leg weakness, which is not a stroke. So a patient who presents with a feeling of weakness on their face, but actually on examination, this lady's got, just go backwards, just do that again. She's got contraction of platysma on the right-hand side, and it's actually, so the contraction of platysma is pulling down the corner of her mouth. She's also got some slight jaw deviation as well. So if you see acute jaw deviation, that's almost diagnostic of a functional disorder. And I think it's probably commoner than we realised. It's something that was described 100 years ago, but rather just got forgotten, I think, but it's been redescribed in the last 10 or 15 years. And sometimes the patient will also have contraction of orbicularis oculus, so it might even be called atosis, although actually the eyelid is normal when you look, but the eye is contracted. Non-epileptic attacks, I'm going to talk about in my talk on epilepsy, so I'm going to talk about the clinical features of them at that time. They're very common. So I've run through some of the positive clinical signs of functional neurological disorders, and you might look at those and say, well, okay, but in fact, none of those signs can distinguish between a patient with a genuine functional disorder who's experiencing that problem and someone who's pretending. And there's no doubt that some patients do pretend. Most of the colleagues I work with in this area, it's very difficult to know how many patients are pretending, but our estimate is probably less than 5% based on quite a number of different factors, and that's also the estimate of the Department of Work and Pensions in the UK, who do carry out surveillance on patients. Quite often when you get surveillance, and I do medical legal work as well, occasionally you'll see patients who are caught out. But it's surprising how often you see patients who are being covertly filmed, and they're actually the same as they were in the clinic. But it is an issue for us. I've got this little clip coming up next this is from a film, it was a film about Sigmund Freud, who was a neurologist before he was a psychiatrist, and it shows him on a ward round in Vienna in 1888. I think it's quite a nice example of how we have problems sometimes with bulimia.
With your permission, I would like to fix it. Yes. Well, we as a up tests here and now, Freud. Gentlemen, I use this occasion to enlighten you as to the true nature of hysteria. Be quiet. This woman claims to be suffering from paralysis of the left leg. In a genuine spastic paralysis, the leg would not be so flexibly rigid. Gentlemen, our paralytic is putting on an exhibition more suited to the Coke theatre than prevailing by war. Her symptoms have been deliberately assumed for the purpose of attracting attention, gaining pity, and escaping the responsibilities of life. Hysteria is another name for life. Pity there's no third yet for that. You will see to it personally, Herr Freud. This bed is vacated at once.
So slightly harsh, one might say. I think those sorts of feelings are very common, I know, still amongst physicians and neurologists. I think we really need to challenge ourselves about the way we think about these things. I think we're worried about being caught out by our patients. But there's lots of reasons why I think that malingering or making things up is not a good explanation for the vast majority of patients. I've shown you already how similar these things have looked for over 100 years. I think talking to patients in particular about the way that their limbs feel is particularly persuasive that we're dealing with a genuine problem here. I'll come back to some brain imaging later as well, which is another strand. This is one study, particularly interesting study I wanted to share with you, which is a study where they asked patients with a functional tremor or psychogenic tremor to wear a watch which was recording how much of the time they were shaking. So these patients knew they were in a study, they knew that the watch was going to give an answer about how much of the time they were shaking. Now the patients in grey, the grey bar shows that the patients thought that they were shaking about over 80% of the day. But what the watch showed was that they were actually shaking less than 5% of the time. These are patients who are in a study, they know that's happening. So there is some discrepancy as well with patients with organic tremor. But I think this is a very interesting study because it tells us that in some of these patients, when they're shaking, when you see them in the examination room, and then you see them walking out and they're not shaking, or they're in the car park, it doesn't necessarily mean that they're malingering. It may just mean that when they think about their arm or look at it, it shakes, and when they don't, it doesn't shake. So it's a bit like asking whether the light is on in the fridge. Well, it is every time you open the fridge door, the light is on. So, and you might imagine that the light is always on, even though you know that it isn't. So I think we have to think carefully about our views about malingering. Now, you may or may not be persuaded about that, but you might say, well, I don't know, is this really my job, functional disorders? My job's to find disease and send the patient away otherwise. The trouble is, that doesn't work either. This is a study, of the same study that we did, nearly 4,000 patients, showed that patients who had symptoms that were completely explained by disease were just as physically disabled as the patients who didn't have a disease at all. So there's not a very good correlation, it turns out, between the presence of a disease and disability, which is perhaps surprising. And if you follow these patients up, as we did in Edinburgh, following up 60 patients with functional limb weakness, 12 years, 80% of them still had their symptoms. So if you just sort of leave them and hope it goes away, well, it doesn't. These patients remain disabled. They have levels of disability that are equivalent to patients with MS for the same duration. And many of them take medical retirement. In the UK, they're quite a big drain on disability budgets, etc. So if we can get, these are young people, so if we get some of them better, we're going to make a difference too, financially. People worry about misdiagnosis, which if you think about it, is completely opposite concern to malingering. Psychiatrists in particular worry. They see a patient with a funny-looking face and a weak arm and leg and think, are you sure this isn't a disease? Well, these are published studies of about 1,500 patients. And what this shows is misdiagnosis of these conditions is about 5%. Well, that's the same as any other neurological psychiatric disorder. In fact, it might be slightly less than people diagnosed as epilepsy who don't have epilepsy. I'll come back to that later. But it's a clinical diagnosis. I think that the rate of misdiagnosis has been like that since the early 70s before we had CT scans. So this is a bedside diagnosis. It's bringing medicine back to the bedside. So what is this problem? What do these people actually have wrong with them? Is it just a psychiatric disorder? Well, I think that's too simplistic. I think we've been stuck with a very rather overly simplistic psychological view for 100 years. Partly Freud has given us that. But before Freud, physicians and neurologists used to talk about diagnosis of functional nervous disease, so it's not a new term. We now have evidence from brain imaging that there are functional changes in the brain of these patients. Now, you've got to be very careful with this. Obviously, you can show more or less anything you want with a functional MRI scan. But I think some of these studies are interesting in that they show changes that do correlate with symptoms. So here's some patients with unilateral functional weakness and sensory disturbance. While they're symptomatic compared to when they got better, while they're symptomatic, there's an area of the brain that's underactive there, which is, if you had a stroke in that area, you would have similar symptoms. You would have heavy sensory disturbance and weakness. So there's something interesting, I think, to explore here. And I think it's reasonable to bring the brain back into the picture in these patients when we've rather dismissed it and viewed it as something which the brain is not involved in. What causes them? Well, lots of things. And there's more here than we could possibly talk about in the 25 minutes I've got. But I think this is a model that has psychological factors at many levels, but also biological ones. So I think very commonly you see patients presenting with limb weakness triggered by something that was a physical trigger rather than a psychological trigger. So you see patients who have a minor injury, they tend to protect the limb, perhaps have been in a car accident, and they're a bit shocked and they have a bit of what's called dissociation. And there's something about that process of an injury or an acute illness that can trigger functional disorders in some people. So for example, I had a patient recently who had a rigor. He had a temperature, very high temperature, at 40, from a viral illness. It settled within a few days. During the illness, he had shaking as part of the rigor. But once the infection settled, he continued to have a tremor of his right arm. And it was a functional tremor. So the rigor had triggered a functional disorder. Now, you could look as hard as you want in that man for psychological reasons why he had a tremor. You couldn't find one. He was working a bit hard, he was a little bit anxious, but really there wasn't anything that unusual. The main reason he had a tremor was because of this experience of this frightening illness. He'd been admitted to hospital, he was shaking. It had done something to him that had triggered the symptom. So I think we need to move away from purely psychological models, but without rejecting them. What about treatment? This is a model of treatment we've been developing in Edinburgh, which is a sort of three-step model, and it really tries to emphasise that the physician or neurologist actually has a very important role in treatment. That's the first step of treatment. If that goes wrong, it's very unlikely that other treatment with physiotherapy or psychological therapy is going to work. So it's very hard to treat a patient who doesn't have confidence in their diagnosis or doesn't really understand what's wrong with them. Now that process, as we all know, often goes wrong and it's challenging. Why does it go wrong? It's worth just thinking about this. Well, if you see a patient with a functional disorder in clinic, if you're a junior doctor, it's quite tempting just to do this. I don't know, let's do some more tests. Maybe you've got Lyme disease. The trouble with that is the patient, you're causing more anxiety in the patient. Being in a state of diagnostic limbo is very unhelpful for the patient, perpetuate the symptoms. Some people tend to say to patients, they just tell them what they haven't got. So you say, okay, you've got tremor, but you don't have Parkinson's disease, this is non-organic, you've got medically unexplained symptoms. You imagine yourself as the patient in that situation. You just think, well, here's a doctor who only knows what I don't have. And I think we kid ourselves sometimes that that's a satisfactory explanation. To say, if you have a problem, you go to the doctor tells you what you don't have. That's not that helpful if you have a tremor. You want to be told what it is. The other thing that goes wrong is the way that you might, if you are trying to explain it, the way that you do so makes the patient think that you're accusing them that it is made up, even when you don't think it is. So you might say, you've got psychogenic tremor, this is something caused by stress, some psychological problem, let's try and find out what it is, and you're being quite sympathetic. The trouble is, now let's see, can we turn the sound up a bit? This is what the Simpsons think about the word psychosomatic, which is all you really need to know because...
You see, class, my Lyme disease turned out to be psychosomatic.
Sammy, you're crazy. Oh, that
actually, it was a little of both.
Okay, so when you use the word psychosomatic or psychogenic, you should know that translates into patients' minds, and I presume it's similar in Jordan, I don't know. Translates to crazy or faking it. So you are making trouble for yourself if you start using words like that, because that's how they're interpreted. Only about 1 in 5 of these patients will a priori believe that stress has anything to do with their symptoms. And so they'll be pretty upset if you start saying that stress is the cause of it. Probably about 2 in 5 of patients don't have any identifiable stress. So they'll actually be right, and you'll be wrong if you say it's stress-related. So you've got to be very careful. And the patient will generally think, well, that doctor just thinks I'm making it up. Even when you're trying to say something different. That's usually what happens. Now, as it turns out, when we explain diseases in neurology, we don't normally jump in with a kind of etiological explanation. If someone's got MS, you don't start telling them why they've got MS. You start by telling them what MS is. You say, well, there's inflammation in your brain, and that's why your arm and leg doesn't work. You might have a discussion about why you have MS, but actually you'll run out of things to say fairly quickly because we don't know why people get MS. So we're doing something a bit different with these patients. We're jumping into an explanation of why very early on, I think, in a way that's not necessarily that helpful. So how can we do it differently? Well, I think we should just do it the same as we do it for every other condition. So if someone's got Parkinson's disease, this is what you do. You tell them what it is. You explain why you're making the diagnosis. You talk about what's wrong rather than why they've got it. So how does that work for a functional movement disorder? Well, tell them what it is. So this is called, you have functional tremor. It's a common problem. I'm going to tell you what it is. There you go. The patient's already got a diagnostic label. They're not starting the consultation with this is what's not wrong with you. The patient will think that usually. That's good. The doctor knows what's wrong with it. I've never heard of it, but he seems to know what it is. I think this is a very important thing to say to patients, if you do believe them. Even if you don't, try it. It might help. That is a massive relief for patients to be told that, to know that the doctor they're seeing actually believes that they have a problem. And colleagues and I have been, over the last 10 years or so, just trying out, showing patients these positive signs, which is something that you wouldn't have dreamt of doing 20, 30 years ago, because these were sort of tricks of the trade you wouldn't share with patients. We wrote an article about it in Neurology. How do you do that? Well, Hoover's sign. You can say to the patient, see how weak your leg is when I do that? That's typical of functional weakness. And then, when they're lifting up the other leg and the weak legs become strong again, you can show them, say to them, look, can you feel that left leg's improved again? That shows me that there's a problem with your brain sending the message to the leg, but clearly it comes back to normal, so it can't be due to damage anywhere in the nervous system. This is a Hoover sign, it's a positive evidence of functional limb weakness. Now that plays out surprisingly well. It brings the authority of the diagnosis back into the examination room. It shows the patient that you as a doctor know what you're doing, and you know that you've made a diagnosis based on the clinical examination. We do similar things with patients with functional dystonia. So what do these signs mean? Well, they mean that your nervous system is not damaged. That means it's got the potential to get better. That fits with a rehabilitation model. And there's a kind of software problem in the brain rather than a hardware problem. Patients get that. Anyone who's got a computer knows that it normally goes wrong because the software's gone wrong rather than because there's smoke coming out the back of the machine. So that's a website that I've made. It's now in 12 languages. It's not in Arabic, so if anyone in the audience wants to make one in Arabic, I'd be delighted to hear from you. It's very easy to do. I can copy it and then you edit it online. So I'm very transparent about these diagnoses with patients. I don't think I'm saying anything that I don't believe. Patients pick up on that. They're pleased to meet someone who knows what's wrong with them, believes them, etc. Now later on, you might want to say, well, actually, here are the 5 reasons why this is not Parkinson's disease. Okay, that's good. You might need to do some tests. Some of these patients have a mixture of functional disorder and disease. I do tend to do MRI scans of patients with weakness. You anticipate that's going to be normal. And then you see the patient again. Now, sometimes, so you ask them that. You've given them a lot of information. You've given it your best shot. And sometimes that happens. And sometimes the patient's a lot better. And it's very satisfying because you've helped that patient get better without drugs, without surgery. And quite often this happens as well. And they can't remember anything you said. They don't remember the website. They can't remember getting a letter. They can't remember the name of the diagnosis. But at least then I feel I've done the best job I can. There's nothing more I can do to help that patient. I might try and explain it again. So that's the sort of stage one of the physician explanation assessment. There are other things to do as well. Obviously making referrals. And for patients with motor symptoms, I think the treatment choice is physiotherapy rather than psychological therapy initially. There's some good evidence emerging about that. But the physiotherapist needs to be familiar with this area. Talking treatment of choice for non-epileptic attacks, dissociative attacks, I'll talk a bit about that later. And there's some evidence emerging there as well. But again, it needs to be a psychologist or psychiatrist familiar with this area. If you send them to a general psychiatrist who doesn't really know about it, they'll often just worry that there's been a disease missed and it won't be helpful for the patient. And there's some trial evidence, I won't labour that. There are other things I think we could be doing. Some of these patients have some success with sedation, so using propofol sedation in patients with fixed dystonia or prolonged weakness can be surprisingly successful. Hypnosis, and we're looking into the role of TMS for these patients as well. But there are undoubtedly many patients with these disorders who don't get better. Now that's the same as MS or Parkinson's disease, so I don't worry too much about it. I aim to help some of them, and some of them I do help, but it's important not to to know when to quit, as well as it is quite important. And those patients are at risk of harm. So, functional disorders, in neurology at least, we diagnose on the basis of positive physical signs. I think physicians and neurologists have a big role to play in treatment, not just diagnosis. And I think if we stick to a mechanism, which is what we normally stick to in medicine, I think that helps a lot with us thinking about the problem and helping patients. Thank you very much.
By Dr. John Stone, and the topic will be the modern trend for management of epilepsy. Again, very common neurological disorders.
Thanks very much. I'm aware that the session slipped a bit. Do you want me to finish a bit earlier? All right. Well, Sorry, would you like me to stop a bit?
No, I think we can cut a little bit there.
Okay. I guess if anyone wants coffee, they can.
I'm 25 minutes.
Yeah, okay, I'll try and go. So, as well as my research interest in functional disorders, I've also been a general neurologist for about 15 years, working a lot in the district general hospital as the only neurologist. So, I'm not an epileptologist, so apologies to any epileptologists in the audience. I think sometimes it's quite good to have a lecture for someone who's not got their face pressed up against the glass. And I'm going to, in doing this talk, I thought, what are the common issues that I come across when dealing with epilepsy, particularly as it's been managed and diagnosed by general physicians in primary care. And it's difficult when asked to give a talk about the management of epilepsy, it's quite difficult not to then go back to the diagnosis, because I think one of the biggest problems I encounter in the general hospital is the patient who's being treated for epilepsy, the treatment's not working, and the reason for that is that it's the wrong diagnosis. Talking to Majid before the talk, he did a study in northern Jordan. 25% of the patients diagnosed with epilepsy in primary care hospital who had a diagnosis of epilepsy actually didn't have that diagnosis. So I think it's important to discuss that. And then if it is epilepsy, what sort of epilepsy is it? I think that's important. I'm going to talk about lifestyle factors. Deciding when to treat the patient with epilepsy and when not to is important. And then we'll run through the drugs and one slide on surgery. These are my sort of top tips, if you like, for the management of epilepsy. It's just always be willing to reconsider the diagnosis, and I do this myself. Hopefully, in someone I've thought has epilepsy, it's turned out I was wrong, and you've got to just continually look at the diagnosis. It's a difficult diagnosis to make and get right. Make treatment decisions about starting treatment very carefully, because once you start someone on an anticonvulsant drug, people are nervous about stopping it, so it's often a lifelong choice that you're making for that patient. Some of you may not know that carbamazepine is a bad idea in juvenile myoclonic epilepsy. That's quite a common epilepsy syndrome. If you don't know about it, it's worth knowing about, looking out for and avoiding carbamazepine for. And valproate has got increasingly big black mark against its name, particularly in women, because of raised fetal malformation rates, because of evidence that children of women on valproate are particularly vulnerable to intellectual disabilities compared to children of women on other anticonvulsants. So if you're using valproate for epilepsy or migraine, don't use it in a woman who's likely to have children, is the message. So let's come on to these things. So making sure it's epilepsy. I wanted to just talk about the phrase tonic-clonic, because I think it's one of the most abused medical terms in the general hospital. People tend to use it for anyone they see who's had some form of event where they're shaking. I think doctors and ambulance men and nurses feel they have to use medical terminology sometimes, when really they'd be much better off just saying what actually happened. Tonic-clonic, it means that there was a tonic phase where the body was stiff, followed by a clonic phase. And the reason for that is because you get these spikes, cortical spikes, which are initially very close together, and that causes tonic movements, and then there's the clonic movements. So that's tonic and clonic. And we could save a lot of trouble and misdiagnosis if people stopped abusing the term tonic-clonic in the general hospital to mean something that shakes, which it doesn't. So let's just look at the tonic-clonic seizure. So here is a tonic-clonic seizure, the tonic phase. It's quite long. And actually that's what witnesses normally say in epilepsy, that there was a person went stiff. That's really what we're looking for. They don't start shaking immediately, and then they do shake. And the shaking is sort of jerky shaking. There's really only three things that make you fall down and shake: epilepsy, syncope, and non-epileptic attacks. And something that is unfamiliar still to a lot of doctors, I think, is just how much people can shake after fainting. These are German medical students who've been made to faint, and the videos show them doing all sorts of funny things after they fainted, including quite vigorous jerking in association. This is just normal syncope. So this is not epilepsy, but it can
Other
be
movements may be
misdiagnosed. So if you get a story of someone who fainted at the dentist, or while they're eating a meal, or had a blackout and then they were shaking, it doesn't mean it was probably not epilepsy, it's probably syncope.
This subject ruffles his hair and looks perplexed, mimicking a temporal lobe type of automatism.
So all kinds of funny things can happen with syncope. And here's someone having a non-epileptic or dissociative seizure. They're having an EEG, being asked to hyperventilate. Now, you might, if you wanted to use terminology, you might say that's a tonic-clonic event. It's not. That patient has actually got a generalised tremor of their body with some symmetrical leg shaking and then an asymmetrical leg tremor. So there was no tonic phase. But this is the sort of thing that gets called tonic-clonic when it's not. And that patient could end up on anticonvulsants for the rest of their life because someone hasn't taken a careful enough witness history. So, now here's some figures. Now I've actually just made these figures up, okay? But just to emphasise that in the diagnosis of blackouts, which we're talking about, the history is everything. Examination, investigations really contribute very little to the diagnosis. People, I'm going to talk about EEG later, but it's really not that helpful in the diagnosis, and you've really got to stick with the history to make a diagnosis. Charles Warlow, who's my professor, mentor, taught me that the most important piece of neurological equipment for diagnosis of blackouts is the telephone. And I think he's right. I think that's what neurologists do, which some other physicians don't. They pick up the telephone, speak to the witness, who saw the event, and you get a completely different story. So the witness history is very important. It turns out that non-medical witnesses actually give better stories than medical witnesses, who often use too much terminology and lingo. But even so, the witness history can be unreliable. So how do you tell the difference between these things? It's not easy, because you're basing it on witness history or patient history. You weren't there, you didn't see it. There are many similarities between these three conditions that cause blackouts and shaking. They can all have warnings, symptoms. In non-epileptic attacks, it may be a bit longer. They can all be incontinent. So by all means ask about incontinence, but it's actually irrelevant to the diagnosis of these three disorders. They can all bite their tongues as well. So some people think tongue biting is quite specific for epilepsy. It's not. Patients with non-epileptic attacks will bite their tongues. What I would say though is if you see this, if you see an actual chunk missing from someone's tongue and a big mark, it's probably epilepsy. If someone tells you they bit their tongue or the tip of the tongue was bitten, it could be anything. What about the description of the attack? Well, body posture, as I've said, epilepsy is all about stiffness with then jerks, but not jerks on their own. Sorry, can I ask the AV people to stop talking, please? In epilepsy, respiration ceases in non-epileptic attacks. It tends to be very fast. And an important clue is that non-epileptic attacks are often very long in duration. So if something's going on for longer than 5 minutes, that's a big red flag that you're not dealing with epilepsy. Patients with status, who present with status to UK hospitals, 30 to 50% of those patients who are thought to be in status epilepticus are actually having a non-epileptic attack. There was a recent documentary on television in the UK from London showing a patient who they said on the BBC, here's a patient with status epilepticus, and they showed them having intravenous treatment. It wasn't, it was a non-epileptic attack. So this happens all the time. If you look at the eyes are very useful. So the eyes are often open in epilepsy, but often closed in patients with non-epileptic attacks. But none of these things are 100%. There are exceptions to all of these things. Something else that is quite specific for epilepsy is the guttural cry. And that's the noise that some patients with epilepsy make just as they're going into the seizure. Hopefully we've got sound in this clip. So it's quite a characteristic noise at the beginning of a seizure caused by a tonic contraction of the larynx, and sometimes you get that from the witness. So if you're happy that it is epilepsy, it's useful to know what sort of epilepsy is it if you're going to try and manage it, because the treatments can be different. And you might look for specific focal features of epilepsy, temporal lobe features that probably most of you are familiar with. But frontal lobe seizures are less familiar, and I'll show you one in a minute. And they can look pretty weird. They can look like non-epileptic attacks. It's important to separate epilepsies between the focal epilepsy, where there's some sort of abnormality in one part of the brain, and the generalised epilepsies, where there's just a general reduction in the threshold to seizures. And particularly juvenile myoclonic epilepsy, which is not that uncommon. As the name suggests, it starts in teenage years. One of the clues in the history there is of morning jerk. So the person's having their breakfast and their spoon drops out of their hand because they're hand jerks. They may not be that bothered by it, but so you have to ask specifically about it as a symptom. But the treatment of those patients is different to for other patients. So here's a frontal lobe seizure. And I can show you the whole of the seizure because it's very brief. So you might look at that and think, well, that looks a bit like a non-epileptic attack. But the difference is it's very short. So non-epileptic attacks tend to be long, you get a bit bored looking at them. whereas frontal lobe seizures are very brief. They start and they stop, and these sort of axial movements are very typical. Skip it. Investigating epilepsy, ECG is absolutely mandatory, I think, for anyone with blackout or possible epilepsy, mainly because you don't want to miss a long QT syndrome, which is potentially treatable, and I think picking up more and more of these patients. EEG, I think, is a very abused investigation. The main problem with it is the false positive rate, and it partly depends on your neurophysiologist and how they read them, but it's very easy to find abnormalities in EEGs if you look hard enough. And lots of people with EEGs, with epilepsy, will have a normal EEG. So it can be a very misleading investigation. And I think it should be used to classify the type of epilepsy that you've diagnosed, not to make a diagnosis of epilepsy. MRI is the imaging modality of choice for epilepsy, for all the things you're looking for. Many of them you can't see them on CT. The investigations don't normally help. You can save a lot of time and effort if you just spend a bit more time taking a witness history, going back to the people that actually saw the seizure. Let's think about treatment. And I think the first thing is to think, well, should this patient be treated? I think most people would say that if someone's had 2 epileptic seizures, that is on 2 separate days. If everything happened on the one day, that's not really 2, that's probably counts as 1. But 2 separate incidents of epileptic seizures, most people would suggest starting treatment because the risk of recurrence there is over 80%. If someone's had 1 seizure, it is more difficult because we know that there are patients who just have 1 seizure and may never have another one. And do you really want that patient to be on lifelong anticonvulsants after just 1 seizure? If they've got a brain lesion, or if they've got learning disability, if they've got a highly abnormal EEG, or if that patient just doesn't want to take the risk of another seizure, then I think there are grounds then for starting treatment after 1 seizure. So if someone, for example, drives for a living in the UK and they know they're going to lose their licence, I know things are different. I'm just saying things are different in Jordan, but there are some people who just will not tolerate a sort of 30–40% risk of another seizure if it's going to stop driving for a year. And I think sometimes we're not very good at stopping drugs either. So if someone's been seizure-free, some people say for 2 years, but others might say 5 years. You should probably review that patient and say, look, do you want to try stopping this drug? Because, and then there are tables that you can look at to work out what their risk of seizure recurrence is and discuss the pros and cons of seizures. I think starting anticonvulsants is not something to do lightly. It's not something to do in the middle of the night in the emergency room without discussion about what it means. Treatment of epilepsy is not just about the drugs, it's about advice as well. So driving. In the UK, you can't drive for a year after a seizure. That has major implications for when you start and stop. What sort of advice should you give to someone about daily activities? Well, I think generally they should be encouraged to try and just do normal activities. I think it's about balancing risks. So if someone works at heights all the time, well, that's probably not a good idea. But I don't think it's the case that you should stop people going up ladders just because they've got epilepsy. So you sort of try to strike a balance between benefits and risks. In the UK, there's a big focus on talking to patients about sudden death in epilepsy. The relatives of patients who've had sudden death are very keen that all patients with epilepsy are told at the outset that this is a condition that can kill you, and it's true, it can. The risk is about 1 in 1,000 though, it's not very high. And there's arguments about whether that's a good thing to do the first time you meet someone with epilepsy, is scare the living daylights out of them about death. Or whether, in fact, telling them that actually helps with compliance, that they are actually dealing with a potentially fatal disorder that requires treatment. So I think that's quite a difficult one. Issues about pregnancy and contraception dominate prescribing women. In particular, recent studies, so this is a pregnancy register from the UK, and other international pregnancy registers are similar, showing that valproate sort of sticks out as a particular offender in pregnancy. Now, it may be that there are something about women who end up on valproate have something different genetically or otherwise about them. So we still have to be a bit careful about this. And there is a dose response. So high-dose lamotrigine is actually worse than low-dose valproate. So it's not just about the drug, it's about the dose. But this is the rate of fetal malformation of these different drugs. So carbamazepine comes out pretty well from these, lamotrigine not bad. There's increasing data on levetiracetam suggesting it's probably okay, but we still need more data. And there's other data suggesting that valproate is maybe particularly associated with intellectual disabilities in children, so developmental problems. So you've got to think very carefully before you give valproate to a young woman. Having said that, valproate can be the best drug for generalised epilepsy. So again, it's about looking at pros and cons with that patient, explaining to them that I'm going to give you this drug, please don't get pregnant while you're on it. Talk to me if you want to get pregnant, or come off it and go on another drug. We were lucky to have epilepsy specialist nurses where we work, and they're very helpful. There's a number of neuropsychiatric issues that go on in epilepsy, which are important. It's perhaps useful to say that antidepressants are safe in epilepsy. So if you're the patient with epilepsy has depression, give them an antidepressant if you want to. They're only dangerous in overdose. That's where this idea of low seizure threshold came from. It came from overdoses. There's no evidence that in normal doses they're pro-convulsant. In fact, SSRIs might even be anti-epileptic. Memory symptoms are very common. Patients worry about them. They think they're going to develop Alzheimer's disease. It's quite helpful to tell them they're not. Yes, it's very common to have memory problems, very forgetful day to day, but it won't turn into dementia. I'm just going to talk briefly about drugs, and my disclosure said I'm not funded by any drug companies. I don't do any trials. I'm not an epileptologist, so I can hopefully give you a reasonably neutral view of it. I think one of the best trials best data sets to look for here is the SANAD trial. Unfortunately, most industry trials of epilepsy are just to get a license. They're against placebo. It's very, very hard to know which drug is better than which other one. The SANAD trial was a drug of nearly 2,000 patients in the UK. And I suppose overall, this is the probability of 12-month remission. What you might say is, well, they're all fairly similar. Gabapentin was worse. I think from this trial in focal epilepsy, lamotrigine and carbamazepine came out best. Topiramate wasn't as well tolerated. So lamotrigine and carbamazepine for focal epilepsy. And then for generalised epilepsy, valproate was probably a bit superior to lamotrigine. I think the topiramate worked pretty well as well, but again, it wasn't as well tolerated. So valproate and lamotrigine for generalised epilepsy. Some other recent studies comparing lamotrigine and levetiracetam showing it's pretty similar actually, there's not much in it. Levetiracetam probably may have a slight edge, but it's pretty marginal. So my take on all this, and the nice guidelines I put in asterisks there, are that the first line drugs for generalised epilepsy are lamotrigine, valproate, and levetiracetam. And those are my first line drugs for focal epilepsy. So that hopefully simplifies it down for you a bit. There are lots of other drugs, of course, so I'm not going to talk about them all. I would say that if someone's been on phenatone or phenobarbital for 40 years and doing all right, just leave them on it. They are good drugs. There are some issues potentially with bone density, but I don't think there's a great need to take that patient off. The patient ideally should not be on more than two drugs at a time. You might want to try 2 monotherapies before going to adjunctive treatment. But you see some patients on 3 or 4 drugs. It's not a good idea. I think when you start getting to 3 or 4 drugs, the patient, they start to cause problems with each other. And some anticonvulsants can end up being pro-convulsant in that situation. If you're trying to choose the drug, well, you've got those initial choices based on the data, but there are also other considerations as well. So younger people tolerate carbamazepine usually pretty well. It's a good drug. It's cheap, obviously. Older patients don't tolerate it so well, so there's an argument for an older patient to go on something else. I've talked about valproate. If someone's got migraine, well then topiramate might be a good idea because it's got efficacy against migraine. If they've got lots of other drugs, they've got liver disease, then levetiracetam is the cleanest drug because it doesn't interact with other drugs. If they've got that juvenile myoclonic epilepsy, you must avoid carbamazepine because it can make myoclonus worse. It's not a good treatment for that particular syndrome. And don't forget that some of these drugs interfere with the contraceptive pill, including allegedly lamotrigine, although it says it on the drug company license, no one's particularly come across that as a clinical issue. And I think there's fairly good experience now that levetiracetam, although it's a good drug in many respects, is a bit of a problem in patients with learning disability particularly those with aggression. Hasn't come out in trials, but I think there's a consensus of clinical experience that it can cause worsening of aggression in those patients, even in people without learning disability. So how much should you fiddle with drugs? If someone's tried lots of drugs and they've still got seizures, and you've gone back and checked that it is epilepsy. Well, some data from Simon Shoreham and others suggests that it is actually worth fiddling. I think quite often people don't try at high enough doses, they don't try different drugs, these things are quite individual. This is a study where they looked at patients who were sent to them with apparently drug-resistant chronic epilepsy and found that a number of them achieved seizure freedom, so 16% of those patients achieved seizure freedom despite having allegedly drug-resistant epilepsy, and 20% had 50 to 100% reduction in seizure frequency. So it is worth fiddling. Obviously, the more you do it, the less return you get. At some point, you do have to give up. And finally, surgery. I don't know what the situation is for surgery here in Jordan, but if someone's got a lesion in their brain that you know is causing epilepsy, and you obviously will want to register that with video EEG, and there might be other things you want to do as well, ictal specs and things like that, then surgery in the right patient can be very successful. Over 70% of properly selected patients will be rendered seizure-free on no medication with the right surgery. And there are patients who probably are not put forward for surgery soon enough. They have obvious hippocampal sclerosis, as you can see in this picture here. If their seizures are causing a lot of disability, there's obviously risks attached to surgery, but I think people are not always aware of quite how beneficial surgery can be in the right patient. There is surgery for non-lesional epilepsy as well, which an increasing research effort into identifying surgical targets in patients. There also has been a vogue for vagal nerve stimulators in non-lesional epilepsy. I think the general consensus there is that they can help a bit, but not as much as people hope they would. So, back to my top tips. I think I would really emphasise, think about whether the diagnosis is right. Could you or someone else have got the diagnosis wrong? Go back and check. Think carefully before these decisions. Think about juvenile myoclonic epilepsy. Avoid valve break in women. Keep going. Acknowledgements. I've got some of this information from NICE, colleague Chris Derry, and also this article in Practical Neurology 2000. So thank you very much.
Now we have short time for discussion. A couple of very important and short questions to our lecturer.
My question is regarding the duration of the treatments. For using monotherapy, for how long will you try monotherapy before deciding to use dual therapy?
Yeah. Well, it's a difficult question, isn't it? Because if someone is having frequent seizures, if they're having 2 or 3, if someone was having 2 seizures a week, and you gave them monotherapy and it wasn't working after 6 weeks, and you pushed up the dose, you might do something very quickly. But if someone has 2 seizures a year, it's quite difficult to know if the drug's working or not. So it's a bit difficult to answer that question. I think it's about whether the patient's satisfied with the seizure control that they've got. If you're satisfied that you've pushed the dose up sufficiently to a dose that they can tolerate, and it's not working and they're still having seizures, it's worth remembering that 17% of patients should be rendered seizure-free by medication. I didn't say that, I should have said that. So, on balance, you should be expecting this patient to be seizure-free. If they're still having seizures, you need to keep trying. That would be the general principle.
My second question, sometimes the patient responding to dual therapy and the frequency of the epileptic fit will become much less frequent. In such cases, we can say that we are still not reaching a successful treatment in such patient, and we need to change the line of our treatment, or this is accepted, I mean, from a clinical point of view?
Yeah, no, I think, well, again, it depends what you've already tried. But if you've, so for example, if it's their first adjunctive treatment, they're on 2 drugs, their seizures have improved, they're happy, but they're still having them. I think that's not a good outcome. I think you need to keep going until, because the studies that we've got showing what happens to clinical populations of these drug-resistant patients is that quite a number of them do much better if you try harder. It may be that the drug you gave them is working, but they can't tolerate a higher dose, or maybe they need to try a different one and then see if they can manage that one at a higher dose. At some point, you have to say to the patient, look, this is as good as we can get it, but I think there is a tendency to not probably push as hard as we should for particularly higher doses. It's not so much trying lots of different drugs. I think it's just probably not trying the drug at a high enough dose.
Thank you. Any other questions? I have a very short question for you, Dr. Stone. Is there any place for a drug treatment in functional neurological disorders? I mean, antidepressants, neuroleptics, etc.
Yeah, that's a good question. I think in terms of evidence, there's no clinical evidence for trials for that. My practice is to use antidepressants if someone has depression or anxiety, and probably about 40 to 50% of patients do, so you end up using them quite a lot. But I'm not convinced that there's something that's something we should just give to everyone, regardless. There are those patients who have these symptoms who are not particularly anxious or depressed. So I think base that decision on their other symptoms. Are they sleeping? What's their mood like? Do they have anxiety? Rather than their neurological symptoms. Probably slightly different for non-epileptic attacks. I would have a higher threshold there because I think non-epileptic attacks in some patients are very much a form through sort of panic attacks and can be treated and looked at that way.
Thank you, Dr. Armstrong, for this nice presentation. And I think it's attract attention, not only the neurologists and medics, but psychiatrists as well. And really very interested, terminology. In 1970s, 50s, they labeled these symptoms, which is unexplained, as psychogenic. And nowadays it is unexplained medical symptom or functional. And I think that we are back to the era even before Freud's and Charcot. And there is a mislabeling in the 1970s when they labeled these symptoms as psychogenic. My question, do you think that these unexplained symptoms, which is not universal to neurology, but we found these symptoms in other medical specialties, do you think that in view of development, I mean neuroimaging studies and finding positive signs in neurology for these symptoms, do you think that one day that comes to find a real explanation for these symptoms? And the second question, we have a problem in following these patients, especially chronic unexplained motor and sensory symptoms, and they just keep running between neurology clinics and psychiatrists. And in view that we don't have the well-established GP system like in Jordan, like in UK, do you advise to see these patients in psychiatric or neurological clinics, especially the chronic cases? Thank you.
Okay, I'll deal with that question first then. I mean, most of the time they're not seen by anyone, are they? Sorry, I think most of the time nobody's got particular interest in them. What I think goes wrong in the UK, at least, is that the neurologist or the physician may make a diagnosis, but doesn't explain that to the patient. I think we really need to move away from the idea that these things are unexplained, okay? Because I just don't think that makes any sense. So if you look at migraine, for example, we're all happy that migraine is a disorder. You diagnose it based on a story. Someone has a throbbing headache, you want to go and lie in a dark room. But you can't see anything really there's nothing to see on a structural brain scan in migraine. We know something about the disorder of function in the brain, but it's still a lot's unknown. We don't really know why people get migraine. Migraine is influenced by stress, sleep, etc. But we're all quite happy to call it migraine. We don't call it an unexplained syndrome. So I would like to see us thinking about these disorders, chronic pain, fibromyalgia, chronic fatigue, other functional disorders, irritable bowel, as not that they're not unexplained. We actually can recognise them and we know what they look like when we see them. You know, any physician knows what these things are when they see them. They know the sort of patients that get them. So we should not be thinking these are unexplained. There are things about them we don't know, but I think that applies to all of the diseases that I look after. So I don't make that separation that you make between unexplained and explained. And if you do that as well, it also has implications for your practice. You think, well, these are disorders within my specialty, and just like someone with MS, I might see someone with MS chronically because they have lots of problems and they're going to benefit from seeing me, but I might not because it might be nothing more that I can do for them. So who should manage them? It depends if that person's helping. If that person's helping them to get better, then they should see them. If they're not helping them, then they shouldn't, probably. But someone in the UK, it's useful to have GPs who protect those patients from harm. So they do come to harm from surgeons, from over-investigation. People don't realise they've got a vulnerability to functional disorders in general. Did I cover both those questions? I think there was an answer. I'm not sure I did. Perhaps we can talk afterwards.
Thank you, Dr. John Stone, for a very interesting talk. I want to ask our local doctors, Dr. Majid, for example, very simple question about the role of nicotinic acid deficiency. Nicotinic acid deficiency. Nicotinic acid deficiency.
One of the slides was on nicotinic acid is the other name of niacin, which is vitamin B3. Nicotinic acid is niacin, vitamin B3. Niacin or nicotinic acid. It's vitamin B3 is two forms: niacin, which is nicotinic acid, and nicotinamide, which is the amide derivative. And it's very rare in developed countries, but in developing countries, niacin deficiency results in pellagra, which is dermatitis, which I showed earlier, dementia-like syndrome, and if untreated, eventually death.
Yeah, I have a question for Dr. Maurice. It's a question. Are your results in your stroke unit, the success of thrombolysis, how they are compatible with the international results? Is it the same percent of improving patients, same percent of patients with their disability?
Thank you. Unfortunately, what we have, most of the patients that were treated in the stroke unit have been very carefully selected, and the numbers are not very high. So I think we can't recommend any conclusions, but I can tell you that at least the number of patients who had symptomatic intracranial hemorrhage is in conformity with the international literature. So the number of patients who had, that's better. I'll repeat. Basically, the number of patients who received thrombolytic therapy are rather small, although we're making every effort to get as many patients eligible as soon as possible to give them this treatment. The number of patients that we thrombolized have done very well, and all I can say is that the number of patients who have symptomatic intracranial hemorrhage are in conformity with the international literature. So basically, they're less than 6 or 7%. And usually, these are patients in one case, for example, I can remember the history was not given to us very carefully, and the others, there was simply either patients who would normally expect at least 7% of patients who have symptomatic hemorrhage. But in general, I cannot tell you because there are 6 neurologists who are interested, who have actually participated in treating patients in the stroke unit. The good thing about it is that there is a protocol that everybody follows, and we are probably on the careful side, which I think is the right way to go. But in general, I'm very pleased with the way it's running.
Thank you so much. I think you Any other questions? Maybe there's time for the last question.
My question is to Thomas. Thank you very much for updating us on the management of ischemic stroke. I have two questions. The first one, usually patients with ischemic stroke, these are the risk factors, and especially diabetes, hypertension, dyslipidemia, and one of them is the target involvement is renal impairment. To which level that thrombolytic therapy is safe to be given in a patient with renal impairment? To which stage of chronic kidney disease? This is number one. Number two, a patient with past history of hemorrhagic ischemic stroke. What is the precautions, and is there any relative contraindication to thrombolyze such patient?
Thank you very much. Now, as far as patients with chronic renal failure, if the patient, it depends really on how you choose the patient. But in general, as far as I can remember, we haven't treated anyone who was actually in chronic renal failure on dialysis, for example. We have seen patients with impaired renal function, and if they are eligible for treatment, you just treat them as you would with other patients. And obviously, you may carry a slightly bigger risk if the blood pressure is not well controlled, or if they are diabetics. And I think you have to appreciate that patients who are diabetic and uncontrolled hypertension, they have a higher risk of intracellular hemorrhage. But if you are faced with a patient who has an occlusion of the middle cellular artery in the dominant hemisphere, I think if you put the pros and cons, you'll find that there are that you probably would go from thrombolysis. I think you have to choose your patient carefully. Now, the other question you asked about
Patients with a past history of hemorrhagic stroke.
Yes. If you have somebody with a previous hemorrhagic stroke, I think he is an exclusion criteria.
Hemorrhagic ischemic, not hemorrhagic.
No, sorry. If he has ischemic.
Hemorrhagic ischemic.
Oh, sorry. Hemorrhagic ischemic. You see, if there is any evidence, this is one of the exclusion criteria. If the patient had a previous stroke with hemorrhagic transformation, I think you have to be very careful about that. That would be an exclusion criteria. Now, you can do special brain imaging where you can become microbleeds. I think this is one of the eras where we go into better imaging for patients. And if you find microbleeds on these patients, there is maybe some evidence that these patients should be excluded because they carry a high risk of intracellular hemorrhage.
Thank you very much. Our time is over. Now we want to thank our lecturers for their excellent presentations. And Dr. Johnson, thank you for your excellent presentation. Thank you for your excellent participation and really Dr. Johnson, thank you for very important lectures. And I want to thank the audience.
Doctor, excuse me, group.